Good morning, ladies and gentlemen. I'm Jonathan Brumberg, the Health Lead for the Solidarity Fund, and it's my great pleasure to welcome all our stakeholders from the Solidarity Fund, our donors and civil society and other interested stakeholders to this very important webinar this morning. We're welcoming Professor Salim Abdul Karim. I'll introduce the Prof shortly. But to get us started, I'd like to hand over to the chairman of the Solidarity Fund, Gloria Sarobe, to welcome us. Gloria, over to you.
Thank you very much, Jonathan. Good morning and welcome to the first Solidarity Fund talk series. The fund has created a platform for us to deconstruct the narratives around COVID-19 and its challenges, giving you, our partners and stakeholders, access to possibilities for critical thinking and analysis around these issues. To recap on who we are, the Solidarity Fund is an immediate response vehicle that was set up 2.5 months ago to augment government's efforts in preparing the country to deal with the pandemic. Our focus is on 3 areas: the health intervention, humanitarian relief, as well as communication and awareness. The health response entails providing personal protective equipment for frontline health workers, while the humanitarian effort is about addressing the challenge of food security and dedicating support to victims of gender-based violence. The communication and awareness effort focuses on inspiring and mobilizing South Africans to act both individually and collectively to flatten the curve and support those who are affected. As part of the awareness drive, the fund last week launched the Citizens in Solidarity campaign to help drive positive and healthy behavior as a key tool in South Africa's fight against the spread of the coronavirus. As the country braces for its peak, we firmly hope that today's discussion, along with many other efforts by many other organizations, will begin to ingrain and cement the behavioral change we so desperately need to secure our future. It is therefore with the absolute pleasure to welcome Professor Salim Karim, the chair of the Ministerial Advisory Committee on COVID-19, who so graciously agreed to share his insights with us here today. I'm sure we are all looking forward to that. I do stand with you today as a citizen in solidarity in the hope that today's session will lead to many more conversations and actions in our fight against COVID-19 and in our continued efforts to help those that are in need. On behalf of the Solidarity Fund, I also wish to express our sincere gratitude for your continued support and solidarity with our mission of assisting the country's medical and humanitarian efforts in our fight against COVID-19. I wish to thank you and now hand over to Dr. Jonathan Brumberg. Thank you very much, Jonathan.
Thank you, Gloria, and welcome Professor Salim Abdul Karim to our webinar this morning. Just to introduce you briefly, Salim is a world-famous clinical infectious diseases epidemiologist. He's the director of a very well-known research and action center in Durban called CAPRISA, the Center for AIDS Program of Research in South Africa. And he is also professor of global health at Columbia in New York and an adjunct professor at Harvard, as well as at Cornell, and for his sins, the Pro-Vice Chancellor of Research at the University of KwaZulu-Natal. As Gloria mentioned, the professor is also the chair of our Ministerial Advisory Committee on COVID-19, but also a member of the Africa Task Force for Coronavirus and a member of the Lancet Commission on COVID-19. I was thinking, Slim, as I was preparing to introduce you, that I think few epidemiologists can reflect back on a career in which they faced these two enormous challenges of HIV and AIDS, in which you made a massive global contribution and continue to do that, and now this enormous challenge. You really are a national treasure, and we're very grateful to have you leading this fight in our country, and we're grateful to have you here this morning. Just before I hand over to you, just some housekeeping. We're expecting that you'll present some slides for maybe 15 or 20 minutes, Prof, and then I will engage in conversation and ask you a few questions, hopefully responding to your slides. For members of our audience, please do feel free to ask questions via the chat stream, and I'll do my best to pick up at least some of those questions towards the end. We hope to finish by 11:15 this morning. So Professor Salim Abdul Karim, over to you, and thanks again. Salim, I wonder if you're on mute, because we're not hearing if you're talking.
You're absolutely right. I was on mute. My apologies. It's a great pleasure, indeed an honor, to be with you here this morning. And I have to start by acknowledging how important the Solidarity Fund is to our efforts. I feel particularly honored to be able to share with you some thoughts on the coronavirus epidemic. And what I hope to do in the next 15 minutes or so is to really give you an update, just to bring you up to speed on where things are and how the epidemic is unfolding. So for those not totally familiar with this, I'll just briefly touch on the origins of the SARS coronavirus 2. So if you look at the picture on the right, that's a picture of the Wuhan seafood market. And they sell a lot of different live animals then besides seafood, including pangolins, which you can see in the picture below. Both of those pictures were taken at the Wuhan seafood market. We know from the genetic sequence of the virus that it is quite similar to the original SARS coronavirus. The SARS coronavirus spread in China 16 years ago. And this particular new virus is similar. In fact, it's even given the same name, SARS coronavirus 2. But there's one very big difference in SARS coronavirus 2. And that difference relates to a receptor that this virus can attach to. And I'll come back to that in a minute. But we now have, based on understanding the genetic code of the virus, we now have some clarity. And it's not entirely clear, it's not 100% yet, but the genetic sequence certainly suggests that the origins of this virus is from the bats in China, and that the bats that are being sold in the Wuhan seafood market, that the virus jumped from the bats into pangolins, and then the pangolins have a very specific form of this virus that the bats actually don't have. And that form of the virus gives it an additional gene sequence that enables this particular virus to attach to the ACE2 receptor. Now, this ACE2 receptor, I won't give you its full name, it's just a complicated name, but just call it an ACE2 receptor. This ACE2 receptor is present in humans in almost all our tissue. You have it in your nose, in your throat, in your lungs, in your liver, in your kidneys, you have it everywhere. And so any virus that can attach to the ACE2 receptor can infect humans in a big way. And the original SARS coronavirus had an ACE2 receptor, but a poorly binding one. So it really petered out. But this particular coronavirus has a high affinity ACE2 receptor binding capability. Why am I telling you all of that? I'm telling you all of that so that you have some idea of why this virus is so unique and why we haven't seen a virus like this that can spread in the whole world so quickly. It can do that because it's not simply a bat virus. It went through an intermediate host, and through that intermediate host acquired this ACE2 receptor. And we know from the coronaviruses isolated from the pangolins that those particular viruses have the ACE2 receptor. So having the ACE2 receptor is what makes this virus so deadly, that it can infect so many human cells. So what are we trying to do in response to this virus? Now that we know that this virus can infect humans in such an efficient way, the primary goal of the South African coronavirus response is to flattening the curve. You heard Dr. Sirobe already describe that, and that's what we are trying to do. And put very simply, we're not anticipating we will have fewer cases. We're just anticipating that we will spread our cases out so that we can cope in the healthcare system. How are we doing in terms of flattening the curve? Well, if you look at the BRICS countries that I've plotted here, together with some of the countries that were very successful, like South Korea and Australia, or some of the countries that were not very successful, like the US and the UK, you can see that we were on the same path as all of them initially. But then when we instituted the state of disaster and the initial lockdown, we were able to flatten this curve. So you can see our curve doesn't go straight up and then bend. Our curve got flattened, got thumped a little bit, and now it's slowly picking up momentum. In other words, we flattened that curve. We started flattening it effectively right from the beginning. But the challenge with flattening the curve is that it's not a once-off event. It's something you have to continually do. And as we've eased restrictions, we have been less and less successful in flattening the curve, particularly in the Western Cape at the moment. And if you look at our deaths, we follow a similar trend. And if you look at how we're doing in relation to the other BRICS countries and the other countries, you can see we follow a similar sort of pattern. We just flattened it. We just didn't have that very rapid initial rise, which would have overwhelmed our service and we would have had a lot of deaths. So what are these deaths that are occurring? Is this from some kind of respiratory virus, as we've been told? You know, the virus is even named, acute respiratory distress virus. Well, we're beginning to understand, and when I say beginning, I literally mean that, because, I must read something like 20 or so articles a day on the coronavirus. And every article I read just tells me how little I know about this virus. In that now we're beginning to understand that this virus goes through an initial respiratory infection. In the vast majority of people, it causes an infection in the nose and the throat, and it'll simply be dealt with. But in a small proportion of people, it goes down into the lungs. And when it does so, in a proportion of those individuals, they get a systemic infection. And that systemic infection leads to quite a dramatic immune response. That immune response is like your body sending messages to mobilize the entire army, navy, air force, everyone to tackle this virus. It sends these signals through what are called cytokines. And so we now understand that when the body creates the cytokine storm, it's sending a multitude of signals, and those signals mobilize our entire body's immune system to fight this virus. And it's that immune response that leads to most of the deaths, not the initial virus. The initial virus itself doesn't do much, it just replicates itself, but it's our immune response. And one of the challenges is that when our immune response kicks in the lungs, the whole of the immune system trying to kill this virus in the little alveoli leads to the lungs getting filled up with pus. When that happens, we can't exchange our gases. We can't get enough oxygen transferred from the air into our bloodstream. And so we go into this kind of a deficit of oxygen. And it's not a traditional respiratory distress. It's a very unusual kind of respiratory distress. And so our saturations go low, we can't get enough oxygen. And so that's why we need oxygen supply, that's why we need ventilators. But this disease, we now understand much more clearly. And if you haven't read this article, it's superb. It's from the journal Nature, one of our preeminent journals. It says every COVID-19 symptom we know right about now from head to toe. And quite literally, this virus affects every part of our body from head to toe. To give you some idea, in the toes, we get a very specific illness that is impacted by this virus, and we only get it from the coronavirus. It's called COVID toes. And in the COVID toes, we have a vasculitis. We have a process of where the small vessels break up and the blood oozes into the tissue, causing the reddish, purplish blotches in the toes that we call COVID toes. And in the brain, of course, it does many things. Headaches is one of the most common symptoms of this infection. And one of the things it causes is stroke. And it does so because of the bleeding disorder that it causes. So we're beginning to understand what was originally a simple respiratory virus is actually a systemic disease. So that's why it's so much more deadly than you would see with influenza or other respiratory diseases. In many ways, this is like a perfect storm. A virus that can readily move from animals into humans and readily move from humans to other humans, and it can move through the respiratory route. In other words, it can be efficiently transmitted. And when it infects humans, it attaches to a receptor we have everywhere in our body with high affinity. So it can very easily infect, and the immune response to it leads to a systemic infection that causes death. So in this perfect storm, that the way in which this virus was created, we were expecting this virus. We didn't expect it to be a coronavirus. When I chaired our government's National Advisory Group on Immunization back in 1993, we together, myself and several others, including Professor Barry Shube of the NIV at that time, the National Institute of Virology, we were preparing for pandemic flu. We even bought Tamiflu and put it into warehouses. We set up the systems to monitor pandemic flu. We set up all of the systems to make a vaccine against it. I mean, we did a lot of preparatory work. And think about it, that's 1993, right? So that's 27 years ago. We as a country, even before democracy, were preparing for pandemic flu. Pandemic flu didn't really arrive as pandemic flu. We had flu outbreaks, H5N1, we had swine flu, we had avian flu, we've had various flus, but none of them could create a pandemic because they didn't have this kind of high affinity ACE2 attachment capability. Whereas all of that preparation we did back in 1993, none of that prepared us for COVID-19. COVID-19 is in a different league. Its ability to spread is what really takes us aback. So what did we do to try and stop this virus? How did we try to deal with it? Well, we learned from the Chinese. And what I'm going to do is I'm going to show you in quick succession how the world implemented rapid stay-at-home restrictions. So on March the 1st, the countries that are colored in blue had no restriction measures at all. The countries in orange had substantial restrictions already in place, and countries in yellow had, call it, lockdown light. They had just very mild restrictions. So if you look at, this is what the world looked like on 1st of March. Very few countries with restrictions. Essentially, you got China and Italy at that time. A month later, 1st of April, look at what the world looks like now. Large parts of the world are under restrictions. 86 countries instituted a national or subnational lockdown. You go 1 month later, on the 1st of May, the situation is even worse now. You've got most of Africa under restrictions. You've got Australia, you've got parts of South America, though South America is still to get its epidemic. But interesting, you see now that China is lifting its restrictions. And so when we look now on the 1st of June, it's a completely different picture, right? The epidemic is spreading still rapidly in Brazil, in Russia, and so they both have restrictions. China, of course, now had its new Beijing outbreak. It's reintroduced its restrictions. In the meantime, Australia and New Zealand, they're playing rugby to full packed stadiums because they don't have any restrictions anymore. And you can see we are now in lockdown light, in the light yellow. So this is just to give you an idea that, sometimes we get so too focused on our own country and our own little issues. The whole world is dealing with lockdowns and restrictions in some form or the other. Well, now we're learning that we actually can't only rely on lockdowns, that our ability to sustain them is constrained, and we have to use our full coronavirus prevention toolbox. And in particular, we really need to use our social distancing, our hand hygiene, and our cloth masks. We're banking on those three to provide the bulk of the protection we need. And then we use our testing, quarantine, our symptom screening, and PPE, and so on, and the environmental cleaning to supplement that. So one of the things we're grappling with, just excuse that. One of the things we're grappling with is our testing capability. And if you look at how we have increased testing over the last 14 weeks, it is just quite amazing. When you think back to when we first started, we were doing 121 tests on average per day. And to think now we are doing almost 30,000 tests per day. And we have very substantial capacity. We could be doing over 100,000 tests a day easily because we built all of that capacity to deal with HIV. HIV, the viral load of HIV, is the basic platform we use for COVID. And if you take the sort of rapid testing we do for COVID, it's based on exactly the same platform as we use for TB, the Gene Expert. So we have no shortage of the machines to be able to do this. And we could be doing hundreds of thousands. The problem is that there's a worldwide shortage of test kits and extraction kits. And so we just can't get enough kits. And that's why we can't do the tests that we would like to be able to do. And so we've got backlogs, we've got long turnaround times, and that's compromising clinical care. It's compromising our prevention because now it takes so long to get a result. By the time we get the result, we're compromising the way in which we allocate patients in the hospital, how we make clinical decisions on them. And we can't do contact tracing because we don't know who's positive. So you can see the knock-on effect is quite substantial. And so we've had to prioritize. And so we've made decisions to prioritize, especially our hospital patients, our healthcare workers, and our outbreaks. So what has happened in this epidemic? Well, before the lockdown, we were going at this and we were doubling our epidemic roughly at about 2 days. And when you take countries like the US, the UK, take the UK because we're very similar to the UK, similar sized country as well. The UK rapidly grew and its doubling time was around 4 days. And when you have a doubling time of 4 days, it's going to go really rapidly. So we were going at roughly the same sort of level at around 2 days, even faster than the UK. But then when you instituted our restrictions, we shifted completely. Our doubling time suddenly just changed, literally. And you saw it in the way our line was with everyone else, and then suddenly our line just changed. And that change occurred because we slowed the spread of the virus and we pushed the doubling time up to 15 days. And since we've started easing the restrictions, our doubling time has increased a little bit in that it's doubling a little bit faster at about 12 days. But at about 12 days, we're still doing pretty well. How are we doing by province? Well, that's a little bit more complicated because the Western Cape, as you can see, even under the tail end of the level 5 restrictions, the virus was already starting to spread. And under the level 4 and level 3, it's been spreading really rapidly. The Eastern Cape is not far behind, as you can see from its doubling time, and Gauteng is taking up the slot thereafter, and KwaZulu-Natal is a distant fourth. So we expect that we will get peaks of this spread of this virus that will vary by province. And it'll be quite different in each province. For example, it will spread much more fast in Gauteng. Based on what we now understand, especially from the US and our experiences from New York, we now understand that in the Eastern Cape, we won't see the same kind of epidemic that we see in the Western Cape. It'll be different because it doesn't have that kind of density that you see in the Western Cape or in Gauteng. So this virus is going to vary province by province. How is it spreading? Why is it that it's spreading in this way? I thought I would use Eastern Cape. I mean, I could take any province. I could take Western Cape if you like. I thought Eastern Cape because it's easier to get a handle on it. So if you look at the Eastern Cape situation, the first case that we saw in the Eastern Cape was on the 21st of March, roughly about 2 weeks after the first case in the country, which was in KwaZulu-Natal. But since then, in April, we had several spreading events. We had an outbreak in the Checkers in Walmer. We had outbreak in the Woolworths in Walmer. We had ShopRite outbreaks. I mean, you can see, you got, just in the Checkers, 33 cases occurring, in the ShopRite, 36, in our supermarkets, in our grocery stores, we've got these outbreaks. And so the staff end up spreading it amongst themselves, they start spreading it to customers, it gets into the community, really difficult to control. But in the Eastern Cape, there was a particular dynamic that has been occurring, which relates to funerals. There was a funeral in Ndwezi, there were 44 cases from one funeral. And then the funeral in Zwidi, that led to 10 cases. And of course, we've seen cases in the Defense Force, and most worryingly, we've seen outbreaks in the frail care facilities in Lorraine and St. George's. And that's really worrying because the death rates get higher there. But to give you some idea of, I'll just give you one impression of how, before you know it, this virus gets ahead of us. So in the one funeral, one Zwedi, there was a small outbreak that occurred at the funeral. It spread at the funeral. One of the people who attended this funeral was a prison warder from the West Bank prison. He took it back to the prison And then he spread it to the other warders and to some of the prisoners. And so we had 29 cases in the West Bank prison. And of course, the warders then spread it to their families and to the households. And so we ended up with 33 cases in the West Bank community. And there was a visiting family from Tanzania. They also picked it up as well. So before you know it, this virus has spread. And part of the problem that it spreads in this way, I'll come to in a minute, but just to give you some idea, so in the Eastern Cape, they have detailed plots of all their cases. So we know where not every, but a large number of the active cases and the deaths that have occurred. And so this diagram just gives you a sense of the geographical distribution of the cases in the Eastern Cape. So why is it so difficult to stop the spread of this virus? Well, first is that this virus spreads before people even know they are sick. It's what is called pre-symptomatic infectiousness. And we now have a better understanding that actually the height of infectiousness is just before the time you get symptoms. So in that 2-3 days before you have symptoms, and then just after you have symptoms, that's the high infectivity period. There are also people who will never get symptoms, and those we call asymptomatics. And so they are spreading it without even knowing they have this virus. And then when somebody has this virus and they contaminate the environment, in other words, they breathe or cough on the environment, it's really difficult to deal with. And so I've provided you with this diagram, which is from an article in the New England Journal of Medicine, where it shows, for example, on copper, this virus dies very quickly, within hours, right? On cardboard, it survives a few hours. But look at stainless steel. In stainless steel, at 20 hours, you've still got more than half the viruses are viable. So we know that on stainless steel and plastic, this virus survives for a long time. 3 to 4 days is how long it survives. That's a real problem. And you can see now why hospitals are really such a haven for this virus. Not only do you have large numbers of infected people, but they have stainless steel everywhere. When I investigated St. Augustine, I couldn't turn without bumping into stainless steel. And so it's a real problem because it's really hard to deal with environments that create the opportunity for this virus to spread. But there are 3 other reasons why this virus is so difficult to spread. It spreads rapidly. And so by the time you know you're dealing with an outbreak, it's already spread. It's infected hundreds of people because it's spreading so quickly. And it then leads to the super spreading events. And I was going to tell you about the patient 31 in South Korea, but I can tell you that in St. Augustine's, the first patient, patient 0, that one person is responsible for 14% of all infections in KwaZulu-Natal. That just gives you some idea how one person's virus can spread in this way. And we call them super spreaders. They are these super spreading events, that they are just these handful of people. That actually a large number of people don't spread the virus because they're good about, wearing their masks and keeping their social distance and so on. But it's just a few individuals where, it just spreads. And then even when you think you've got it under control, it comes back in another wave. And almost every country now that had the virus under control, Singapore, South Korea, China, every one of them have had repeat outbreaks. As you know, China had an outbreak in Wuhan, and of course, last week, they are now dealing with a huge outbreak in Beijing. And Beijing, that they need to worry about because you've got so many people, that's like a New York waiting to happen. So they've got to really control that virus to stop it spreading in Beijing. Well, we defined very early on what our health response would look like. We at the tail end of stage 4 of our community program, and we've moved beyond that of our active case finding. Now we are focusing on our hotspots. We got to try and control the spread from the outbreaks. If you remember, I talked about that we got to watch for the flames, because these little flames, before you know it, they become raging fires. And when they're raging fires, there's almost nothing you can do. You just stand and watch. You know, we've got to get these flames, and we've got to get them under control. And right now, we're trying to find flames with basically a blindfold, because we don't have enough tests. We don't have enough tests. We don't know where the cases are. We don't know where the cases are. We can't deal with these flames. So we really are in a difficult position right now to control this. And while we're fighting the flames in the hotspots, in the Western Cape, of course, they're really dealing with the challenges of medical care. As you know, in the Western Cape, the Cape Town ICC is now an 800-bed field hospital. And of course, with all of that comes the death and the bereavement we have to deal with, and the vigilance. I'll end off by just capturing where we are now and the challenges we face. This response changes. The epidemic changes, our response changes. You have to be able to respond as this virus changes, and as the way in which it spreads changes, as where it spreads, how it spreads, and as our knowledge improves. And so we now have a better understanding that actually we're not dealing with just something that's going to occur over a month or 2 or 3. We have to deal with this virus like it's going to be with us for several months, if not years. And so I talk about planning for a marathon, not a sprint. And in the solidarity front, you have to be thinking along similar lines, in my view, because we're going to be dealing with this epidemic and this virus for quite a while. So these are the 4 sort of stages. You initially have the epidemic, where the virus is spreading and you're trying to flatten the curve. And then when you've successfully flattened the curve, as you have, for example, in Australia and New Zealand, by the way, island nations have a big advantage. And you know, many island nations are declaring victory. So Fiji has already declared elimination, Mauritius, Cuba, New Zealand. So island nations are in a different situation to the rest of us. But they get to what is called containment. Containment is where there's very low sporadic spread transmission. And when you get to that stage, you can then coexist with the virus. And so we talk about lifting the restrictions and and using our mitigation measures to coexist with the virus. Now, of course, in South Africa, we couldn't get to containment. Containment was always going to be very difficult for us to attain. And so we're doing things a bit the other way around. We moved from epidemic because we couldn't sustain our lockdown and our movement restrictions. We had to switch, and while the epidemic is spreading, we had to switch to coexisting with the virus. And we hope that at some stage we will get to containment, because once you get to containment, then you're basically waiting for a point where there's a vaccine or cure. And that's when you can, in a sustained way, resume your normal activities. So we are planning on the basis that we will be living with this threat probably till the end of 2021, maybe well into 2022 as well. That South Africa, like India, Russia, Pakistan, is a whole slew of countries that are all in exactly the same boat, that we are lifting restrictions while cases are increasing. We are lifting restrictions without containment. And the big problem is, as you lift restrictions, you enable the virus to spread even more. And now our main strategy is about mitigating with prevention. So we're trying to use our tools to mitigate our risk, and we're trying to control outbreaks. And so we are transitioning from a situation of anxiety to self-efficacy, empowering people to self-implement prevention. So I'll just end off by saying that, yes, we did successfully start flattening the curve. We're starting to see the rapid spread in the Western Cape. Eastern Cape is a few weeks behind. We're seeing our outbreaks. And South Africa right now, because we're easing restrictions while our cases increase, we are in that damned if you do and damned if you don't situation. It applies to whether you talk about schools or workplaces. You will see outbreaks occurring. You will see the spread of virus because we are easing restrictions while virus continues. And our major challenge is to keep focus on the coming surge and shifting our message to self-efficacy of protecting myself, my family, and my community. Thank you very much. I'll stop there. Just unshare that.
Thank you very much, Prof. It was, as always, incredibly erudite and very, very helpful to get your update. I'll start off by asking you a few questions, and I wonder if I could ask you to share your screen again, your slides. I'd like to ask you to go back to near the beginning of your presentation where you showed the South African curve relative to some other countries. And I wanted to ask you to start off with a question there. Yeah, that's the slide. Thank you. So, you, I think, very clearly showed us the significant impact of the lockdown on bending the curve downwards very sharply. And I think the question in many of our minds now is, where is this curve now pointing and where's it going to end? Because you can see on your slide, some countries flattening off a little bit. China is a very good example. And obviously you mentioned Australia and South Korea, but, do you see us being able to, bend this curve so that it starts to flatten at some point in the future? If so, when? Or does this keep going up and up at this quite sharp angle?
When you look at the way in which our cases are increasing, we are basically following the same trajectory as Brazil and India. We're just at a lower level. If you look at the angle, it's very similar to Brazil and India. And so we are likely to see several 100,000 cases based on what we're seeing now. We're just at about 100,000 cases at the moment. I don't know at what point it's going to level out. I think we're not going to be in a situation like China, South Korea, or Australia. I think we will be more like what we've seen in India. India had the same ability. If you look at India's line, you see how it deviated early on from their early lockdown. There's a little kink in their line right at the early stages, around day 12 or so. And then they drop their line, not as sharply as ours. But I think we are likely to see a similar picture, which means we'll probably go up to a few 100,000 before we see this leveling off. And the reason I say that is because of what we've seen in New York, and in fact, what I saw in the HIV epidemic, that once you get to a situation where most people know someone else who has this disease, a family member, a neighbor, somebody in the community, a famous person, it becomes personal. It's not now something we're just doing for some unknown virus that we can't see. It becomes personal. And you do that, people change their behavior. I saw that in HIV very well in HIV, that as the deaths started going up, people changed their behavior. In New York, they did exactly the same. As they saw the virus spreading and as they began to know people, they changed. I'm optimistic that the work that the government is doing, the work that you are doing, the work that many other NGOs and others are doing will help speed that up. And if we can do that, we'll flatten it much more earlier than I anticipate.
Thanks. That's very helpful. Prof, the key mechanisms to achieve that containment, as you say, or the flattening, are testing. And as you've described, we do face constraints. And my understanding now is that we're focusing mainly on healthcare workers and hospital patients under investigation. So that means there's a real risk that we'll struggle to identify the hotspots, as you call it. Secondly, contact tracing. So, and then thirdly, obviously, people adhering to social distancing and hand hygiene. Could you comment on where you think we are on all three of those at this point, on the testing, how effective is our contact tracing, and are we getting the message across properly on social distancing and self-protection, as you described it?
I think our efforts initially in contact tracing were very variable across the provinces. I think when we most needed a really concerted effort on contact tracing was right at the beginning, because contact tracing has a huge impact when you only got a handful of cases. When we were around 1,000 cases or so, up to around 10,000 cases, we needed to do better with our contact tracing. The problem was that we didn't have the wherewithal at that stage. It was just too early in the epidemic. And the efforts that were made, I think we probably did pretty well. Pretty well meaning, probably more than half of all the contacts were traced. We were able to quarantine them. That's why we were able to move from doubling of 2 days to doubling of 15 days. But what we didn't have was the ability to contain the virus. To get that is really a challenge. And in a situation like ours, where large parts of our community can't social distance, can't wash hands in the same way, it's really it was always going to be a stretch for us to get containment. So when I first described it, I put containment as a low outcome possibility. I always worked on the basis that we were going to see an epidemic. It was almost inescapable because of that. Now, when we look at what we're doing in places like Gauteng and in the Eastern Cape, we still have the opportunity for contact tracing and quarantine to make a difference. In the Western Cape, probably not to the same extent. It's probably just too far-seeded in the general community. But other provinces, especially the other three of the four big provinces where we're worried about the epidemic, I think that contact tracing and quarantine is important. That means we've got to get testing done. And that means we've got to get enough kits. So that's part of our challenge. I mean, let's just be clear. We are doing a lot of testing. To do 30,000 tests per day, that's a lot of tests. So it's not like we're doing a trifling amount of tests, but we do need more. And I think because of the rapid spread in the Western Cape, they are consuming a large fraction of our kits, which is correct. That's how it should be. They have the burden there. But it means we have less and less kits to do the outbreak investigations, to stem the tide of the spread, because it's the same tool we're using for clinical management as we are using for prevention.
And Prof, so assuming you're making the point that contact tracing is still very important, especially in the bigger provinces outside the Western Cape, what could be done to improve the efficacy of the contact tracing from where we are at this point in time?
In most of the four big provinces, we actually had a big head start, because of our TB epidemic, we already have teams of people who do contact tracing. We didn't have to hire them. We didn't have to train them. They already exist. I mean, KwaZulu-Natal, which I know quite well, we have whole teams of people that just do contact tracing for TB. And large sections of those were reassigned to work on COVID, so that we did have the teams. The problem has been twofold. One has been that we have had difficulty getting people to adhere to quarantine. Quarantine is not an easy thing, especially when you go beyond quarantine to isolation. See, for those who test positive, we need to institute isolation. Isolation means you can't interact with anyone else. Your food has to be made and brought to your door and left outside, so that you open the door, take it in, and then when you finish, you leave the empty plate outside. So to do that was going to be very difficult. Now, that's what they did in Wuhan. In Wuhan, they had the ability to really do isolation. And they had that big red flag system that the Chinese described to us. I mean, our meetings with the Chinese were just amazing when they shared with us their experiences. And the same when we met with the Russians. You know, we meet as the MAC. We meet with all the other countries. Our next meeting is with the US to learn from them. And they want to learn from us too. I digress. But I have seen how countries succeed if they can do this. But our societies, it's difficult. We can't do it to the same extent like they can, because people won't follow the rules.
But are you saying people won't follow the rules because they cannot, because of social circumstances, or is there something uniquely challenging about our society that people don't like following the rules?
Yeah, I misspoke. A large number of people follow the rules. But as you know, in this epidemic, it's those few that don't follow the rules that pose the super spreading risk. And that's where we have a problem. And to me, it's a combination of the two. In some instances, they can't. In other instances, people are just tired. They're tired of sitting at home. They're tired of wearing a mask. So yesterday, I had to venture out to the supermarket, and I went into through the suburb next to mine called Overport. Overport in Durban is our highest density suburb. It's basically full of big apartment blocks. And as I was driving through, I was struck that, you know, less than half the people were wearing masks. And I said, I mean, if you ever needed a mask, you need it in Overport, and you're not wearing a mask. It's really, that's a problem. And unfortunately, we can't really enforce that now. To try and enforce that, you know, with police and so on, I think is really, it's going backwards. We already tried that, doesn't really work well. It leads to things we don't want to see. So we have to enforce it differently. We have to enforce it by every one of us encouraging everyone else to wear a mask. And that without enforcement, it means we have to convince people. And that's a problem. You can never convince 100% of the people. And that 20% that you don't convince, they pose a risk to all of us. They're not posing a risk to themselves because they're often young people. And they pose a risk to everyone else. And that's our problem. I don't have a simple solution, but I can tell you that I think one of our best chances is what the minister is doing right now. I mean, the minister, as you know, he's thinking 5 steps ahead of all the rest of us. And when we sat down and we discussed what's our next strategy going to be some 4 or 5 weeks ago, it was, well, how do we mobilize communities to really take up our prevention strategies? And so you heard about the new MAC that was created. that new MAC is to do exactly that. And all of this had to be be conjured up quite a while ago. But in my view, the role of the MAC that I'm part of, our role is now going to be more technical in medical care. Who do we really need? We need this new MAC. This new MAC has got to guide us, help our government, help our people figure out how we're going to get people to take up these prevention measures.
Thanks, Salim. Yeah, I think that, you've made some very important points there, that this failure by some part of the population to comply with these measures is multifactorial. There's clearly social conditions. In some people, there's ignorance of, the messages. I wanted to ask you about one specific trend that I've picked up, and there's actually a question in our chat stream here, which says, it seems inevitable that most of us will get COVID. Many feel we should get on with our lives and just get it anyway. And if you're not a high-risk person, is there any reason to try and avoid it? Maybe younger, healthier members should just get on and not even try and avoid it. How do we, I know my answer to that, but, what's your view on answering that question?
So some have tried that and came out the worse for the wear. And if you take, for example, Sweden, that started up front when Tagno, who is my equivalent in Sweden, when he recommended to the Swedish government to go this route, which was very simple, ask most people to work at home voluntarily. Don't institute any restrictions. Let the restaurants carry on, let the schools carry on, and all we do is try and protect the elderly. And we will try and aim to get to herd immunity in Sweden. Well, a couple of things happened. They had outbreaks occur in Stockholm in Sweden more widely. And Sweden now has the highest number of deaths in the whole of Scandinavia. And if you take the most recent survey that was done in Stockholm, only 7.3% of people in Stockholm have antibodies. They are nowhere near herd immunity. We don't know what herd immunity really is for this virus, but you can do a rough calculation that it's somewhere between 60 and 70%. That means you've got to wait for 60 to 70% of people to get infected. You better have a lot of graveyards ready if that's what your plan is, because it's not a viable plan. Really, it's not a viable plan. The plan has to be that we try to control and contain. To the extent we can't, we mitigate, and we try and keep the fraction infected to as low as possible until there's a vaccine. Now, some have asked me, what's your plan if there's no vaccine? That's a plan that I don't have right now, actually.
Prof, just to carry on with that, I think, to add just my own perspective for a second, I think is to make the important point that, you may think statistically you're in a low risk group, but it's impossible to predict, when a young, healthy person will become severely ill and die. And I know from our data and discovery, we've got many of those people, 25-year-olds, many below 35 or 40 who are becoming severely ill, and some of whom are dying. So one message in response to that question is, you don't know when it's you. Mm-hmm. And secondly, your point, I think, to emphasize your point again, which is you have a responsibility to everybody else to keep safe, because you may come through it safely, but you may well infect other people at the same time. So I think that's a very clear answer. Mm-hmm. You were on the herd immunity question, Prof, and one of our audience is asking: is the concept of herd immunity still relevant in the COVID-19 epidemic?
At this point, I think it's something we have to keep in mind. there are two fundamental problems with herd immunity in COVID. The first is we actually do not know whether you can get reinfected if you've been infected before. So that means we actually don't know whether a person who's infected has protective immunity. We think it's likely to be the case, but we don't know it for sure. And we don't know for how long. Even if you do have some protection, we don't know how long that protection would hold. You have the additional problem that this virus is going through genetic drift. So because of its proofreading step, I didn't go through the details of how this virus replicates, but because it's got an additional proofreading step, it just makes one change roughly every month. Roughly every 30 days, we see one change in the amino acids that we see that make up the protein antigen. So that means that when you've had millions of infections, and when we've been through about a year and a half of this virus, the virus will be antigenically different. So we don't know whether there'll be a variant of this virus at a point in which you are hoping that your previous immunity protects you. So you see the problem we have. We don't know whether the immunity protects, we don't know for how long, and we don't know whether it'll protect against a variant that we're likely to see in about a year and a half from now. So herd immunity is a big stretch right now because of that. But we have to keep it in our plans because it's really the only basis on which we can protect the nation. We don't really have anything else right now. Without a vaccine or a cure, we don't have any other strategy in place.
And while you're mentioning the vaccine, could you give us your sense of what's the progress at the moment? What do you think are the prospects for an effective vaccine or more than one? And if so, when do you think the timing is? And when would we see it in our country, which I think is a different question?
I think of the vaccine candidates that we have in the world. So WHO keeps track of this. We now have in excess of 125 candidates. And actually, the New York Times on their website has a nice little tracker. Of the 125 or so, 7 of them are in phase 1 safety trials. 7 of them are in phase 2 immunogenicity trials. Only 1 vaccine is in phase 3. That's a vaccine made with a chimp adenovirus with an insert from the coronavirus. That vaccine was manufactured. The inserts were put in by researchers from Oxford University. And it has shown pretty good data in animal studies. And its immunogenicity is quite reasonable. And that trial is in phase 3. It's quite far advanced in the UK. It's just about starting in South Africa. It's going to be in several countries. The one thing about that vaccine is that there are already plans in place for manufacturing. And India, the Serum Institute, have already been preparing to manufacture several hundreds of millions of doses. It's because, to get to a vaccine you got to do all of the research that takes you to a point where the vaccine is efficacious. Then you actually have to manufacture it. And we're going to need billions of doses in order to vaccinate our world's population. So it's not going to be anytime soon. To start with, just the vaccine itself, just to be able to show that the vaccine worked, it's going to take a while because we're going to have to vaccinate tens of thousands of people because your attack rate is low. So when you think about it, you got to, let's say, for example, if we were doing the study in Durban, we would probably have to vaccinate, 10,000 people or so. And we'd have to hope for an attack rate of the people we vaccinated of around 5%. So that means that we will probably see about 50 infections or so. Now, that's too little to know whether the vaccine's efficacious or not. So that's why we have to do it in multiple countries. Then, even if the vaccine is efficacious, we need to know how long it's efficacious for. And in a chimp animal, because there's no other vaccine ever made like this, we need to know how safe it is. Because you can't go around vaccinating young people who have a very low risk of the virus causing severe disease when the vaccine may cause severe disease. When you're vaccinating billions of people, even a small risk of a serious side effect takes on a new proportion. So we're facing many hurdles on the path to a vaccine. Fortunately, we're actually tackling this on multiple fronts. So there are several candidates that are actually built on existing platforms. So those are protein subunits. Those are vaccines that we have a lot of experience with. We know how to make those quickly. We can make it in bulk in many different factories. But when we get to like the current Moderna vaccine, which is an RNA-based vaccine, we've got no track record. We don't know how this behaves in humans. And the similar with the chimp adeno, we actually don't know how it will behave in humans. So you can see the problems. I'm giving you too many problems, but I can say I'm actually optimistic. And the reason I'm optimistic is because of the change rate in the virus being so slow. That means if we make a vaccine, that vaccine will probably be effective for quite a while. And until we get a genuine drift in the virus, that vaccine will be a pretty good vaccine that should protect us if it is immunogenic.
And if you were to try and guess when one might expect doses of one or more of these to be available here, when do you think that might be?
I think optimistically, the end of next year. That's a very optimistic scenario. I'm being overly optimistic, let's just say. I think more likely 2022.
So as you say, this really is not a sprint, it's a real marathon. And our job is to persuade our country to be patient and to live with the need for behavior change in a very sustained way. It's just life is not going back to normal anytime soon. Is that the message? You'd agree with that?
I think we have no choice. I mean, I really hope I'm proven wrong. I mean, I desperately want to be proven wrong here, and that, we'll have a vaccine soon. We've never had a vaccine in less than about 7 years. Every vaccine we've ever made has taken long. If you take HIV, my own field, I've been working on a vaccine for 31 years, and we don't have a vaccine. Right? So with most vaccines, we don't actually get vaccines quickly. There's no such thing as a quick vaccine. This COVID is changing all paradigms on how we make vaccines. And I'm optimistic that it'll succeed. And I think that means that we still have to prepare for at least the next year, 2, maybe even 3 years, where we have to live a new normal.
And Prof, what's your, just turning to care now, to our hospitals and the healthcare system, what's your sense of how ready we are? How is the Western Cape been coping as they approach their peak? And what's your sense in KwaZulu-Natal, in Gauteng, and the Eastern Cape? How will the healthcare system cope when those provinces reach their own peaks?
Because I'm not in the Department of Health, I actually don't know the details. I just have a bird's eye view. I can tell you that we will never be ready enough. I don't think any country can be ready enough, ever, because the number of ICU beds needed, we just don't have them. They just don't exist. And the number of staff required and so on, we can never have that. I think what we need to be is ready enough. We're just sufficiently ready. And that would mean that we wouldn't see what we saw in Italy and in New York. I mean, in New York, patients were dying in the corridors of the hospital. They hang at the door because they can't get in because there's so many patients there. So if that ever happened here, we would have failed our nation. And I hope that we will never see that. So I don't think we're going to see that. And the reason I don't think we're going to see that is I think we've got good overflow and we've created a good structure with our field hospitals so that hospitals are protected. So your Provincials, your Tigerbergs, and your Karl Bremmers, they are protected. Protected means nobody goes there unless they really need to be there. Everyone else, we deal with you in a field hospital. You need to be admitted, we admit you, put you in a field hospital. But we keep and we protect our main hospitals because that's where we're going to have to look after the most sick, the ones that are likely to die. That's where they're going to have to go. And we're going to have to do our best to protect them. I think that strategy was implemented in New York at the tail end and worked quite well. You can drop your mortality of deaths with that strategy if you do it properly. So I'm pretty optimistic that the way in which we've tackled it and the way in which the surge capacity has been planned, and I have to say, I mean, I watched this committee doing their work. You know, it was a committee chaired by Ian Sunny, and they really did superb work. I mean, just to give you some idea, we are going to need a lot of oxygen. The amount of oxygen we need is well beyond our current capabilities. So they looked at how can we increase production? And if you increase production to capacity, we now understand better that actually that will be a big difference. It pretty much doubles the amount of oxygen we'll have, but still we'll be short. So we now understand that there's about 70% or so of the oxygen that goes to commercial, not medical. That goes to big factories that need oxygen. So we're going to have to redirect that for a period of 2 or 3 months just to have enough medical oxygen. So then we need to know, do we have the storage capacity? It's one thing to make all this oxygen. Can we store it? And can we store it in the right places? And that's what they've planned out in detail. There's a whole Deloitte's team that sat down and worked all that out. How long will it take to get oxygen from storage to the main key hospitals in each province? Detailed planning has been done. So we now are in a much better position. Imagine if we were dealing with this in March. At least we're dealing with it now. And now we know we can get oxygen to most people. We'll probably still be short, but we will not be anywhere near a disaster situation that we would have had in March, that we are in a better position right now. So when I look at all of that, I feel like we are in a much better place. But I have to say that we are in a situation where we are expecting a health service that has quite a substantial number of weaknesses to rise to the occasion. I'm not sure we really have the capacity to be able to do that uniformly. And I worry particularly about places like the Eastern Cape where, you know, the basic infrastructure is struggling just to get the laundry done. And when push comes to shove, they are going to need to really develop capabilities that they haven't been able to develop over many years. And I think to the extent that we can build the bridges between the public and private sector and make them more seamless in the way we deal with it, I think that's part of our solution. And the reason is that there are more ICU beds, more ICU capabilities in the private sector than we have in the public sector, substantially more. I mean, in Durban, St. Augustine's has 58 ventilators. There's no public hospital with 58 ventilators. So St. Augustine's is going to be our #1 hospital to go to. It's going to have to deal with the bulk of the people that we will need ventilation for. So to plan in Durban to have a response that doesn't include St. Augustine's is just nonsensical. So I'm just using it as an example of we're going to have to do things that we haven't been able to do before to create a seamless flow between public and private that has been a challenge for us for many years.
Yes, as you say, it has. I think the good news there is that there has been a lot of progress, as you will know well.
Yes.
And it seems like, we already are on the brink or have already agreed for that collaboration in most of the provinces. So I think that is, there is some light at the end of the tunnel of this epidemic, which, as you say, we're learning to do things we never did before, including speeding up vaccine production and this kind of public-private collaboration. Prof. Karim, let me say thank you. It's right on 12:15. I do apologize. Several of our audience have asked questions. We've managed to answer some, but we can't answer them all. Several of you have asked for recordings of this webinar. It will be available this afternoon on the website of the Solidarity Fund and also on YouTube. So you can, anyone who wants to hear this again or to share it can do so. So that leaves me just to thank you, Slim. As always, it was beyond our expectations, incredibly helpful. And we are grateful for your work and for your time. Thank you. Thank you very much. And thanks to all who attended today. Thank you.
It's a pleasure. Bye-bye.
Bye-bye.